Hi, this is Ruth Werner, and welcome to this audiovisual sidebar that will accompany my article on fibromyalgia. This little piece is where I'm going to do a little bit deeper look at what we understand about the pathophysiology of this condition, which is frankly not a lot, and it's constantly moving, but it's worth taking a look at because, of course, these issues are some of the things that our clients are dealing with. So I'm going to try and do this pretty quickly. And, if you're interested in more, there are lots and lots of resources for you to pursue about that. So rather than talking about the pathophysiology or even causes of fibromyalgia, the people who study this are more likely to talk about its components. Because the diagnostic criteria for fibro is still a little bit up in the air and constantly being, refined and challenged and honed, which is good. But this also means, and we know this from observation, that many people who fit many of the diagnostic criteria for fibro don't fit others. It's tremendously diverse in the way that it presents, and it can be very diverse in the way that it presents in any individual person. So a person who has fibro may have several of these components, or only a couple, or they may switch off. And the other thing I want to point out about these components is that they're not mutually exclusive. They connect to each other. They may overlap each other. You can make an argument that some of them cause each other. All of this is still, in exploration. So we're going to look very briefly at HPA axis dysfunction, dysautonomia, the sleep disorder that we see with fibro, central sensitization, one of my least favorite topics, neurotransmitter imbalances, tender points, and then I'll give you just a short list of other things that are turning up in explorations about fibromyalgia. You ready? Here we go. Okay, HPA axis dysregulation. You might remember, and if you don't, I'm going to tell you anyway, that the HPA axis is a linkage between the hypothalamus and the pituitary gland and the adrenal gland. That's what HPA stands for. And this chemical and neurological linkage between these structures basically regulates the efficiency of our stress response system. What we see for people who have fibro is a dysregulated HPA axis. And this reflects as in the way that they tend to secrete more stress-related hormones, especially cortisol. Those hormones are present in the bloodstream for longer periods of time, and their recovery time from stressful events tends to be more slow. So their resiliency gets a little bit worn out. We see HPA axis dysregulation as a factor in many, many disorders beyond fibromyalgia. This is another representation of this, which I thought was pretty helpful. So if we see here at the top, it's the hypothalamus, which is the little glob of tissue in our brain that sort of runs the autonomic nervous system. And it connects to the anterior pituitary gland, both physically and by way of this hormone, corticotropin-releasing hormone. Then the anterior pituitary, under direction from hypothalamus, releases ACTH, adrenocorticotropic hormone, and that acts on the adrenal cortex, which then squirts out a bunch of cortisol, which is one of our stress-related hormones. And our cortisol levels in the bloodstream will rise until the hypothalamus and the anterior pituitary gland sense that we have achieved the desired levels, and then this communication system will stop. And that's a nice example of a typical endocrine system negative feedback loop, but with people who have fibro, but also people who have anxiety and depression and chronic fatigue syndrome and a variety of other things, including sometimes long COVID. We see disruptions in the HPA axis, and that means our ability to deal with stress becomes harder. It becomes less efficient, and stress is more likely, stress in the form of both emotional and physical challenges, is more likely to wear us out. Dysautonomia turns out to be a big factor in fibromyalgia, and this is a big term. Dysautonomia just means dysfunction with autonomic action. And you can make an argument that a dysregulated HPA axis is simply a reflection of dysautonomia because, of course, at the center of this is the hypothalamus. What we see with people who are diagnosed with this condition, dysautonomia, is they have problems regulating temperature because their autonomic nervous system is not helping to maintain that stable internal state. Often this is reflected that they have really hard time with heat toleration because they don't sweat much. And a lot of people with fibromyalgia also have this condition called POTS, which stands for postural orthostatic tachycardia syndrome. And that's a situation where if someone is laying down or is sitting and they rise, their blood pressure to the head drops very quickly, but the heart rate goes way, way up. And it's uncomfortable, and it can cause dizziness and fainting and all kinds of other really unpleasant problems. And we see this a lot with fibro, with chronic fatigue syndrome, with long COVID, and several other things. And it's all part of that dysfunctional autonomic response system. We see that people who have fibromyalgia have issues with sleep. If you read the article, you will see that that was a really, really common through line in the commentary that I got from everybody who participated, that they felt they did not get good quality sleep. And what it really comes down to, we have learned from fibromyalgia studies, is that people with fibro have disorganized sleep and they get little or no stage 4. So what I've given us in this graphic is a typical sleep cycle. We enter from wakefulness into stage 1, and in a healthy sleep cycle, we'll then proceed to stages 2, 3, 4, 3, 2, and REM before we go back into stage 1. And of course, REM sleep stands for rapid eye movement sleep. For people who have fibromyalgia, what we find is that their sleep cycle is sort of all over the map, leaping from one stage to another, but spending little or no time in stage 4 sleep. And that's a problem because stage 4 sleep is when we secrete growth hormone. Now, you might think that growth hormone is something that only children and pregnant ladies have to secrete. That turns out not to be true. We all secrete growth hormone, the hormone that prioritizes the rebuilding or new production of cells, because we all have to heal from everyday little injuries and insults and wear and tear. If someone isn't getting stage 4 sleep and they have reduced secretion of growth hormone, which is supposed to happen during that stage, that means injuries are going to heal slower, more pain, more interrupted sleep, and it continues to reinforce that negative cycle. There was an early experiment where we learned about fibromyalgia and sleep disorders, where this researcher, Moldavsky, was able to induce the signs and symptoms of fibromyalgia within just a few days of interrupting people of various types. We had various ages and sexes and activity levels. And within a few days, almost everybody started developing the signs of fibro when their stage 4 sleep was disrupted. And that is a little chicken and eggy, right? Because we don't know if having a dysfunctional sleep disorder causes fibro or if having fibro causes a dysfunctional sleep cycle. Either way, if we can get into that circle and help to improve the quality of someone's sleep, this is a way that we can help to improve at least the symptoms of living with fibro. Central sensitization is a situation where in the central nervous system we see structural changes. We grow new neurotransmitters, we secrete different kinds of hormones or neurotransmitters. And so we have these structural changes in the brain and the spinal cord that do two things. They make us more sensitive to incoming signals about pain. I forgot to introduce Trudy. This is a character named Trudy that I developed with my graphic artist, and she is our person who's living with fibro, and Trudy is having a hard day. She is experiencing central sensitization. And what's happening in this situation is that within her central nervous system, all of her incoming sensory receptors are more sensitive to incoming messages, more likely to translate or interpret those incoming messages as pain. And her ability to mitigate that or to filter out those incoming messages is very, very limited, again, because of those structural changes. And so one of the ways people often describe central sensitization is as sensory amplification. Everything is more. Textures are rougher. Cold is colder. Hot is hotter. Light is too bright. Smells are too intense. And this is what it's like to live in a fibro flare if someone is experiencing this central sensitization. Another factor that we see in most people who have fibromyalgia is this weird phenomenon called tender points. And I don't have time in this setting to go down this rabbit hole of comparing tender points to trigger points. There was a long time where people did not delineate between those two things. And then there was some pushback, and we realized that tender points behave very differently from trigger points. And the reason I've chosen to give you this picture of Trudy is that her massage therapist is pretending or not understanding that the tender points in her upper back are not trigger points, and what they don't need is deep sustained pressure. What we see with tender points is that they appear in all 4 quadrants of the body. They appear often in 9 predictable pairs, and they tend to be hypotonic and locally painful. And that helps to distinguish them from trigger points, which tend to be hypertonic and to refer pain to distant areas in the body. So here are a couple of different tender point maps. I think these are a little more interesting than the typical person in anatomical position that we see. And, here's Trudy. And what we are trying to convey with these red spots that are a little fuzzy around the edge is that just a very tiny amount of pressure on these areas will cause a completely out of proportion pain response. And that pain may diffuse over that area, but it does not, say, refer to the jaw or some distant part of the body, which we are more likely to see with trigger points, not tender points. So we have talked then, I'll see if I can remember these. We talked about the HPA axis, dysautonomia, central sensitization, tender points. And these are all components, well-recognized components to fibro. I will say for those tender points, let me go back here for a moment. I will say about those tender points, we used to consider these a diagnostic test for fibro, and that is no longer true. You may have heard that having 11 out of 18 tender points is a positive sign for fibro. Tender points are no longer considered absolutely necessary for a diagnosis. We have some pain-related questionnaires that are actually more sensitive about that. So those are the things that are, making their way into the literature now about basic components of fibromyalgia, but people who are studying this are constantly looking for more to deepen our understanding of this condition. And among the possibilities we are seeing here is inflammation in the central nervous system. And this is kind of important because if you read the article, you will see that in our earliest days of observation, the names we gave to what we now call fibromyalgia all implied inflammation, fibrositis and myofibrosis and fibromyositis. And then in the 70s, we began to biopsy those tender points and found no signs of inflammation. That may turn out to have been a premature statement, although the inflammation that we're seeing associated with fibro may be more located in the spinal cord than out in the tissues. So it's something that some people are studying. Small fiber neuropathy refers to specific damage to some of our sensory neurons. And there is a pattern that some, but not all, patients with fibromyalgia show signs of having this particular kind of neuropathy. Mitochondrial dysfunction is another line of inquiry into this. If our mitochondria in the muscles don't function well, if they don't produce ATP, if they get clogged up with garbage or metabolic wastes, then we're going to possibly have pain and fatigue and dysfunction. Or there could be entirely things, new things that we haven't even considered. So the big question really is, does it matter? For massage therapists, if we can determine that there's nothing going on for this client that our work will make worse, or if we can determine that we can offer a session that won't make this person feel worse, which is really the key question, then these queries about pathophysiology are maybe a little less relevant to us, but they are very relevant to our clients, because through these inquiries, we may finally develop a way to actually test for fibromyalgia so that someone can have a definitive diagnosis, which would make a huge difference for people. Understanding more about fibro will help us understand more about the conditions that are often seen with fibro, like chronic fatigue and irritable bowel syndrome and chronic pelvic pain syndrome and migraines and TMJ and long COVID. Understanding more about the pathophysiology of this condition, obviously, will provide us with some ideas about treatment options and maybe even someday ways to prevent this from developing. So this is all sort of generational thinking, but the time to do that obviously is now. I want to thank you for joining me on this little exploration of fibromyalgia components as an accompaniment to my article on fibromyalgia. And I hope that you enjoyed it and found it useful. Thanks.